So to introduce ourselves, I'm Dr. Rachel Hughes. I'm one of the Neurodisability consultants at Reigate. I'm a paediatrician by background. So over to Caroline.
So good afternoon, my name's Caroline Bleakley and I'm also a neurodisability paediatrician, and my role is leading the ADHD service at the Trust.
Hello, my name's Katie Driver. I'm a consultant child and adolescent psychiatrist. I'm based at Bayton Community CAMHS, which is one of the community CAMHS teams at the Children's Hospital, and I lead the neurodevelopmental pathway for community CAMHS. And I'm here today from a neurodevelopmental perspective rather than a mental health perspective.
Hello, I'm Louise Watkin. I'm a clinical specialist in CAMHS. I'm the lead for CAMHS lead for Kenwood and Chapel House, and my role in a nutshell is to provide consultation and advice to the staff at the schools, but you might see my name all over the System 1 record, so it'd be helpful maybe for you to know who I am and put a face to that. So I also support with the network, so providing mental health consultation and advice to sometimes GPs who are in that network around the child, as well as parents and other professionals.
Okay, over to me then. So I'm going to start out by giving you some clinical headlines around ADHD. ADHD and autism go very much hand in hand, so I'll be followed by Rachel, and then Katie's going to give us some particular insight into our pathways, and then we'll open up for questions around any aspect of anything neurodevelopmental. Okay, so there's so much to cover talking about ADHD clinically. So what I want to do this afternoon is help you understand ADHD in 2025, because as a team of clinicians, there's been a huge amount of new learning for us, and we'd like to emphasise that for you. ADHD, of course, is an entirely treatable neurodevelopmental condition. We want to share experiences with yourselves out in primary care and ourselves in secondary care. We're aware there's a very big treatment gap currently across the UK. We want to improve your confidence and hopefully demystify stimulant medications. These are not dangerous medications in physically well individuals. Everyone blames a stimulant, don't they? And so hopefully we'll be able to demystify some of that. But above all, in Sheffield, we want to work together. We can't do this without your input and expertise. So we really do want to work with you. And there's work currently looking at Sheffield being very innovative and citywide work for ADHD. Okay, so what makes us think about ADHD? Well, I started ADHD in the 1990s when our founder, Val Harpin, felt that ADHD was something that should go hand in hand with psychiatry. And the service aimed to see everyone in Sheffield across the whole of the city in one clinic a month. Very sadly, our psychiatrist died on vacation very suddenly, and hence it started to grow up in paediatrics. And at that time, we were very much frowned upon as sole paediatricians working within ADHD. It was felt to be, back then, perhaps a more complex condition that maybe would sit better in psychiatry services. And there was no nice guidance back then to guide us. And of course, now we do have nice guidance, which I guess increases confidence that ADHD can be supported by any suitably trained professional. So back then, I guess clinics would have been full of active boys, and it was rare to see girls and women back then. and mainly very externally presenting, super hyperkinetic boys. And there was still a lot of scepticism, feeling that ADHD was perhaps naughty boys with poor parents, and we've hopefully moved right away from that now. And I think most people do recognise ADHD, particularly with social media interest, in terms of the core symptoms. And there's two domains we look at if we're going to be making a diagnosis. We look at inattention and hyperactivity impulsivity. And it's true to say that all of the traits in ADHD can be seen in the general population, unlike autism. But when we're looking at ADHD, we're looking at often, very often, and with impact and impairment. And I guess the key point today is ADHD is not a concentration problem. It's a disorder of top brain function, executive function. And we have to take a deep dive into 9 areas of inattention when we're doing our assessments, looking at planning, organising, getting started, because the key problem in ADHD is not enough dopamine. And if we don't have enough dopamine and the top part of our brain isn't functioning as it should, starting and carrying out any task is really, really challenging. And ADHD is very impairing. It's important to remember that individuals with ADHD have an interest-led brain, a brain that can hyperfocus if there's something that captures interest. And therefore, we often get in school, well, they can't have ADHD because they focus beautifully in geography and they're just lazy and they can't be bothered because the rest of the time they're not paying attention. And ADHD is not a disorder of not knowing what to do. We know what to do. We don't have enough dopamine. We don't have the ability to do this. We also look at hyperactivity. And in this day and age, we recognise that hyperactivity can be entirely internal. It can be a very busy brain that won't stop mind wandering, and it's very disabling. And that hyperactivity can also be very subtle and difficult to spot for the untrained eye. It can be picking skin, biting nails, twirling hair, or it can be talking too much or giggling. So it can be busy brain, busy body, and it can be very subtle. And likewise, impulsivity can be verbal or actions, and this part of our profile with ADHD can get us in real hot water if we're very automatic and we're doing and saying without thinking, because it's just an automatic action. Not very well spoken about because it's not part of the DSM-5 diagnostic criteria. But we now know that ADHD is far, far more than just the core symptoms. That's ADHD in its simplest form, is emotional dysregulation. And this is what often gets muddled up with mental health. But there are 4 quick questions to unpick it. First of all, neurodevelopmental disorders start in early childhood, and we're not born with a mental health problem. So we look at what is your baseline. But emotions aren't mood, they're reactive to day-to-day events. So, for example, when you found out this afternoon that it was going to be ADHD, you might have thought, oh, that's all I need. I really wanted some up-to-date hot topic from medicine. And we can all feel disappointed depending on what happens in our day, but times that by 100. And these feelings are instant, they're automatic, they're embarrassing, they're not nice. And at the peak of emotional dysregulation, some individuals will use self-harm as a way of coping because it feels so awful. So 4 characteristics, they're immediate, we can see what the problem is, they're reactive to a situation, entirely understandable. We can see why you're upset. So child wants to go first in a race and they're not able to, but there's a big meltdown. It's the reaction is over the top, it's excessive, very short-lived, so everybody else is sweating and they're back to baseline. And this happens throughout the day. Very, very different to mood, and that's important. We said that impairment needs to be present to make a diagnosis. No impairment, no diagnosis. And adults will roll in and out of reaching diagnostic threshold, depending on what life does to them. So if you find your niche, you find your tribe, and you're very well supported, you may not hit diagnostic threshold. But if you're suddenly mum of a new baby and there's 2 people to look after and you don't have a wraparound, you may suddenly tip back into threshold again. And this is just the diagnostic framework. Why does treatment matter? Well, we said that ADHD is defined by its core symptoms in its most simplistic form, and that's true. But it is an executive function problem and therefore an emotional regulation problem. However, it has very important physical health links, and this is the new learning. ADHD in childhood carries twice the mortality rate, 4 times so if that runs on to adulthood. ADHD in childhood will take around 8 years off your lifespan, and that will increase to 13 if it runs untreated and unsupported into adulthood. Why? Let's pull back the curtains. Lots of you will know about the risks of untreated ADHD, and here are some of them. I guess ADHD is almost worse at every measurable outcome, isn't it? We can just times it. Unplanned pregnancies, criminality, school dropout, self-esteem. These are just some of the risks. But we now know, partly through genetics and partly through gut-brain axis and other mechanisms, we can talk about it in more detail another time, but there's a massive link between diabetes, hypertension, obesity. Probably 40% of people that have BMIs in the 40s might have ADHD, migraines, epilepsy, autoimmune condition, POTS, and a lot of these individuals fared really poorly in COVID. A lot of them were left with long COVID. And so why is ADHD a public health condition relevant to primary care? Well, this was the first study, but it's been replicated in the UK as well. This is Russell Barkley. He's in his 70s now. He has a YouTube channel and puts out lots of science-based clips if any of you are interested and want to look further. He followed a group of kids with ADHD and age-matched controls right through to adulthood and put their characteristics into a life expectancy calculator, and that is how they found out that there was a reduction in healthy life expectancy. And what's very interesting is 9 out of the 14 things that he put into the lifespan calculator are actually amenable to change. So with a bit of dopamine and with work, we can change that. So these slides I've included for your reference, really. I'm going to really whiz through because we've a lot to cover. But just ADHD, it's really prevalent. 5%, 5 to 7% of the childhood population and almost 3% of adults. It's not going away, although adults roll in and out of needing diagnosis. Is it increasing in prevalence? We can talk more about this, but there's strong genetic evidence to say it isn't. It's just the recognition has improved more recently. And that's just a helpful paper with lots of evidence-based information for your reference. ADHD is very strongly genetic. Tall, just like height, you know, tall parents, tall children, parents with ADHD, children with ADHD. So if you're seeing a child in your surgery with ADHD, there's a 50% chance the parents will have ADHD and a 25 to 40% chance the siblings will have ADHD. And that affects how the condition is managed. I'm not going to dwell on this, but there are environmental risk factors that act as well in genetically susceptible, such as prematurity, and the paper that I've given reference to is free. There are a number of high-risk groups where ADHD is particularly prevalent. And so when these individuals turn up in surgery, we have to think about, is ADHD part of the profile? ADHD is very comorbid, and it's not usually either or, it's usually all together. Women are not men, and therefore those that have cyclical hormones have to be treated differently. Hormones, estrogen and progesterone, affect ADHD, and therefore in the second half of the cycle, the luteal phase, ADHD medicines are often less effective. Those that have high IQ are going to present very differently. They're going to mask and camouflage their difficulties. And so if you're meeting somebody with a higher IQ, they're far more likely to be an internal presentation. However, there's a trade-off. Masking either ADHD or autism is exhausting. So they might end up being misdiagnosed as chronic fatigue because of the boom and bust, or depression, but think, because these individuals have often got underlying ADHD or autism profiles, and the higher your IQ, the more likely you are to have both together. So about 80% of people with ADHD and high IQ will have autism, and they're masked, but there are clues that we can look for. So in the interest of time, I'm not going to go through all the features for girls and women, but I've given you some slides for your own information. Just to say, a lot of primary school girls and boys that have an internal presentation go under the radar because everything's measured in academics, and high IQ carries you quite a long way. This is really of interest to general practice if you're thinking about ADHD in the 17s and above. This is free to download, the Adult Self-Reporting Scale. And if you score 4 out of 6 on the first 6 questions in the shaded boxes, you're 80% likely to have the symptoms of ADHD. But as we've said, you then need assessment to look at impact and impairment, but it can be very helpful. And that's the paper behind it for reference. Just to remind me that individuals with ADHD till mid-20s, their executive function is delayed behind their actual age by up to 1/3. So when they go to university, it can all fall down without the wraparound of the parents, and we have evidence for that. We do have objective testing to help us identify individuals when things are overlapping and comorbid, and this is just a QB test to remind us. They do have to let insurance know, but they only have to let the DVLA know if they think their driving is affected by ADHD. And we give driving advice. Very quickly, medication, because that's the mainstay actually, isn't it? Stimulants are not dangerous. The main pathology in ADHD is not enough dopamine. Methylphenidates recycle, amphetamines recycle dopamine and increase production. Main side effects really, ADHD has cardiovascular risk in its own right. The main issue is blood pressure and pulse. They do increase, so we have to monitor them. And if they are elevated, we treat blood pressure in its own right. Appetite suppression we can usually get round by being creative and having our 3 meals and snacks over 24 hours for brain food outside of the time that the stimulant's on board. But we do have non-stimulants as well, and we can talk more. That's what we do in titration, and we are aware of the stock issues. We get somebody lovely, stable and optimised, and the medicines disappear, and we can talk more later. And that's just to remind us about hormones and pregnancy that, again, we can come to later. So in the interest of time, we're going to move on to autism.
Thank you. Right. Hello, everybody. It's lovely to be here. I just want to reiterate that I think we've got a lot to learn from each other. I'm not going to stand here and tell you exactly what to do. I think there's a lot of people in this room with professional, personal, family experience. So I'm going to try and do this in about 15 minutes. Okay. So thinking about how we might define autism. So again, our understanding and the definitions of autism have changed somewhat, similar to ADHD over time. But essentially, you're dealing with a difference in social communication. And that's not just, can this child speak, but do they use their language to make a meaningful connection with somebody? There's a spectrum of impact across different domains. And of course, what I'm really interested in is not if this person has a few quirks, because that's fine. I'm interested in, is this getting in the way? Is this causing a disability? Okay. So similar to ADHD, there is an impact on your mental health and physical health. Sadly, we know that mental health problems are much more common in autistic people, and the rates of suicide are much higher. The rates of dropping out of school and finding meaningful employment are also lower. So although I've put up that stat of 31% of autistic adults in work, I believe that's actually lower if you look at full-time paid employment. So I think that stat for Sheffield is 7%. Very sad. Okay. So in my work diagnosing autism, sometimes the question comes up, well, why do we diagnose? And I think that is a good question to ask. And for some young people and for some parents, it's not the right time or the right question. I want to see children or young people or parents where they are actively seeking a diagnosis, where there's evidence of impact. And having some information from you guys about whether they are consenting to the referral, whether the parents understand why they've been referred is really helpful. Overall, the evidence is that diagnosis is helpful. It's not like ADHD where we can treat with medication, but actually there is improvement seen with mental health, both in that child and also in the parents. If you look at things like early intervention, that's a good reason to diagnose early. Having said that, we are working really hard in Sheffield to make sure that as much as possible does not depend on a diagnosis. So as much as you can possibly do should be needs-led and not rely on a diagnosis. We do struggle, you will all know, with our long waits, and I think there's something like 10,000 children on our waiting list currently for an ADHD or autism assessment. Clearly that is not on, okay? There is, even if we increase the number of clinicians doing these assessments, we're never going to see all these children. So we need to have a real think about how we prioritise, and that's also a really uncomfortable conversation to have. So I'm going to think about what we might be able to do, for what we can do, but also what you can do if you have a child where autism is suspected or diagnosed. Okay, so either way, these are things that may be amenable to support in some way. Okay, so starting with coordination difficulties, really common. Okay, even if you don't meet a threshold for a DCD diagnosis, which a lot of the kids will do, developmental coordination disorder, lots of children have struggled with things like self-care skills or ball skills or that sort of thing, and that can be quite impairing in itself. So all of these things that I'm going to mention now, obviously there are different ways of supporting them, but you can refer in separately to these areas without needing a neurodisability paediatrician to do that. There's also lots of information from the motor skills team about coordination and how to improve a child's self-help skills on their website. And they also have the sensory workshop with a link to how to get help for sensory needs on their website as well. And parents can do that themselves, so you don't even have to do that. Obviously, physical exercise is good for everybody, but this can actually be really helpful in terms of making sure that people feel a valued part of their community as well. The other thing is schools can also use their motor skills programs. That's the other thing I was going to mention about that. So going on to diet, clearly we see quite the extremes of eating within the children that we see. And I am slightly concerned that my threshold for a good diet has plummeted in the last few years. Just a few things about that, really, because obviously you can talk about children's eating for a long time, but a few key things. Firstly, we have seen children with significant vitamin A, vitamin C deficiencies, and lead poisoning secondary to Pica. So do have a think about those and think about whether you need to send off any blood tests. There obviously is there a support available from the dietitians. As I said, my own threshold is probably the beige diet is just universal as far as I can tell. But if a child is taking multivitamins, is having a fortified breakfast cereal, is on a reasonable centile, then I find all those things quite reassuring. But you may want to seek additional help, I suppose, what I'm trying to say, outside those parameters. Okay, sleep. So most of the children that we see do have a degree of sleep problems, the most common being sleep onset delay. Clearly, there is a pathway for referral on for sleep, but it's making a difference to somebody's sleep, can be really transformative for parents. So if you do see somebody with sleep difficulties, then I think that is really something that you can actually really make a difference on. Toileting. So again, a really common difficulty, which needs its own talk, really. But part of this is because if you're autistic, you don't feel your bodily sensations in the same way. So your feelings of needing to go for a poo, or your feelings of, oh, I'm actually full of food now, they don't always feel those feelings in the same way. So sometimes you need a little bit more extra help with that. There is obviously good advice from Eric, their website, and the continence team if you need to refer. Sometimes alternative strategies are needed, and reassurance to parents that potty training is hard. Dental health, again, big topic. There's often a sensory need with toothbrushing because the sound and the feel of the toothpaste. There is toothpaste which you can get which is not flavoured, so that's a good tip. There's also the specialist dental health team. And the last picture is just to remind me that audiology is quite helpful if you can get a hearing check if you've got a child with a speech delay. And also SLT, so speech and language therapy, do great work. Obviously, they're also very much in demand and have their own difficulties with managing their waiting list. but they do have access to lots and lots of support, especially for the preschool children. So you can do an attention autism course with your child to learn how to interact with them without needing a diagnosis. So that's just a reminder there. Okay, so I think we're going to do questions at the end, but I've just, like, my final point I'd like to make is that sometimes we can come across as quite medical and quite negative about autism and ADHD, and there are so many positive things, and I can think about all the wonderful things that I have learnt from the children I have seen over the years. And sometimes it might feel a little bit like you are dealing with a breaking bad news situation, or it might be tricky to raise the concerns or have these discussions with the families that you are seeing. And I think there certainly is a grief reaction for lots of parents. However, we're also really trying to be positive about neurodiversity. And if you can encourage the parents to think about the good things, the strengths of their child, because it would be really boring and if we didn't have a variety of people in our lives. Okay, there you go.
Okay, so I've got the practical bit, so that's the clinical part done. This is going to be potentially the bit more controversial bit, hopefully not too controversial. As Caroline and Rachel have both said, we really want to work with you guys because we're much stronger together than separately. So as I've already said, I'm a child psychiatrist and I lead the neurodevelopmental pathway. That's within CAMS. So the part that Rachel and Caroline work in is Reigate, which is the neurodisability paediatricians. I'm in the mental health team, so as I'll come on to this, there are two different ways to get an assessment in Sheffield for a neurodevelopmental condition. So this is just a quick recap. That's my only clinical slide. So a range of neurodevelopmental conditions. So I lie there are 4 ways to get an assessment for autism or ADHD in Sheffield. Within the Children's Hospital, we've got Reigate and we've got CAMS, and then there's also Right to Choose and private providers. So Reigate, and please, Caroline and Rachel, correct me if I've got anything wrong here. So we have SPA, which is single point of access, which is the point which you guys refer into when you've got concerns about a child who might have ADHD or autism, and they take referrals up to the age of 16 years old. When the single point of access receives the referral, then screening forms are sent out to parents and school to complete, and then they're returned to Reigate, to single point of access, and then they're put into a grading queue for triage, which when they get to the top of that list, all the information is looked at in the referral form and in the questionnaires that went out to parents and school, and a decision is made to either accept or to reject that referral. Those that are accepted, there are 2 separate waiting lists, one for autism, one for ADHD, and these are the current waiting times. These are publicised on the Children's Hospital website, so there are no, this is not hidden or private information, and it is getting updated periodically. As you can see currently, preschool autism wait of 3 years. These are the waits for if you are added on today for an assessment, so it will depend on at what point you were added on to the waiting list. School age autism, 7 years, and if you are referred today for an ADHD assessment, you will wait in excess of 8 years, and that reflects the 10,000 people that Rachel mentioned that are waiting to be seen at Reigate. Those that have been already on the waiting list for several years, you can reduce those numbers accordingly. There isn't a routine offer in terms of follow-up for autism. Don't hang on to people once they're diagnosed with autism. Medication is offered for those who are diagnosed with ADHD. The other place within Sheffield Children's Hospital where you can get an assessment is CAMS, which is where I work. So to be seen for an ADHD or an autism assessment in CAMS, you already have to be under us for a mental health condition. So you need to have a moderate to severe mental health condition. And that's what we get referrals for. So when you guys see a young person and you're concerned they might have a moderate to severe mental health problem, you refer them to CAMS. We can then accept them onto a waiting list, presuming that they get through our triage. They get put on our waiting list. Our current wait is actually down to a year now. And then they have an initial assessment in CAMS of their mental health. If at that point it's felt that this young person, in addition to their mental health difficulties, may have an underlying neurodevelopmental condition and that needs assessment, we will screen for that within CAMS, and then we have our own internal waiting list for autism and ADHD assessments. We have a combined list, so we don't have a separate autism and ADHD waiting list, we have one, and the current waiting time is 2 years. So, sorry, that waiting time, that's wrong. I was told this today, that's down to 1 year. So we're actually 1 year for an initial assessment. And then once you're on our internal waiting list for an assessment for autism or ADHD, you will wait another 2 years. So as I've emphasised here, you guys will be referring in to us for the mental health condition, and then we will pick up on that within CAMS in terms of concerns about neurodevelopmental conditions. In terms of follow-up, we have an autism follow-up clinic and we have an ADHD follow-up clinic for those that we diagnose, and that is whether they whether they want meds or not. So we will keep on those that don't want medication as well as those that do want medication in terms of follow-up. So right to choose, which has definitely taken off in the last few years. It has been around for longer, but people are obviously hearing about the long waiting lists nationally, and they're turning to right to choose because traditionally the waiting lists have been shorter. We are seeing an increase in waiting lists for the right to choose now because everyone's going to right to choose, so their waiting lists have gone up as well. So patients have a legal right to choose their healthcare provider, and right to choose referrals have to be made by primary care. We can't make them within secondary care. And it's up to you if you deem it to be clinically appropriate. If you deem it to be clinically appropriate, then the patient has the right to choose where they wish to be assessed. So we're not able to recommend one right to choose provider over another. And what they offer really does vary. So some will just do an assessment and a diagnosis and then out. Others will diagnose initially, do the titration of medication, and then they will finish. And others will do ongoing prescribing and monitoring. To be a provider, you can be commissioned by any ICB or NHS England, has to be led by a consultant or a mental health professional, and they have to be CQC registered. What we ask of you as GPs is that you discuss with the family what you are willing, what you are willing to offer should they go down the right to choose line. Because if families are going to go to right to choose, they will have a wait for that, they will have an assessment. If at the end of it, they're wanting you guys to do shared care or get involved with ongoing prescribing, if that's not something you're willing to offer, we just ask that that's a conversation that happens at the point when the family comes to you and says, I'd like to be referred on right to choose. And then in terms of, we often get asked, both at Reigate and at CAMS, about taking on the prescribing of people via right to choose. And again, correct me if I'm wrong, at Reigate, if the family go and get a right to choose assessment, they don't jump the queue at Reigate. So they have to be on the Reigate waiting list, and they have to have those waiting list times that I've just referred to. So you don't just jump to the top of the queue and say, I've got a diagnosis with you right to choose, can I have meds? No, sorry, you have to wait with everyone else. So again, that's something that's important to make families aware of, because many families will go through right to choose expecting that they can then jump the Reigate queue. So and again, the fourth option is private providers. So families can choose to access a private assessment, which can obviously be very costly. Quality is variable. Again, we can't recommend individual providers. And again, it's about letting the family know if that's what they want to do. This, as GPs, is what we are prepared or not prepared to do post-diagnosis with your private provider. When I was asked to talk today, I asked Emma, what do you guys want to know? And some of the questions that came back were around transition, which is why I've included this in here. So this is my only touch on mental health. So from a neurodevelopmental perspective, so SANS are a diagnostic service. So that's the Sheffield Adult Autism Neurodevelopmental Service. They do not take transfer of care for young people who are diagnosed with autism or ADHD for follow-up. And I can guarantee you they don't, because we try and refer people to SANS. They do not accept them. So they are a diagnostic service. They have a 5-year wait for all referrals. They are planning a reassessment of needs clinic, which hasn't taken off yet. The aim is to have a shorter waiting time for that. So that would be for cases where they have a diagnosis and they either need a medication review or they've come off medication, they want it restarting, retitrating, or there's questions around, it's a particularly complex case or whatever, and they will see them. They have to have a pre-existing diagnosis to get into the reassessment and needs clinic. This doesn't exist yet, it will exist, and the hope is there'll be shorter waiting times. There is a SANS inquiry line for primary care to access for advice about medication. I haven't included it on there. I can share it once I have had it confirmed, because I have asked for that as confirmation from SANS. The only people who have ADHD medication prescribed in secondary care are those who have an uncontrolled mental health condition, whose the adult mental health team, typically CMHT, have agreed to take on. They also have ADHD, and that ADHD can then be managed by the CMHT psychiatrist. So I've recently transitioned someone who has very poor mental health. CMHT agreed to take on. They have a psychiatrist, they have a care coordinator, they're just on an SSRI actually. From a mental health perspective, the psychiatrist has agreed to take on the prescribing of the SSRI. They also have ADHD, which isn't well controlled, it's not well optimised. There's been various engagement issues as to why we can't optimise it. It's a key part of their profile, which if managed well will help their mental health. CMHT psychiatrists will manage that ADHD medication. I'll come back to it. SANS are a diagnostic service. They won't see people from a medication perspective. So when they diagnose with ADHD, they will start meds, they will titrate and stabilise, typically 3 months, and then they're done. From a mental health perspective, we have a transition clinic where we can refer young people into adult services who we believe have a mental health condition which warrants secondary care. I estimate, and this is a ballpark figure just from experience, I think under 5% of all cases in CAMS, when they leave us at 18, go to CMHT, go to Adult Mental Health Services. So that means 95% are being discharged from CAMS back to primary care. Their thresholds are really, really, really high. Unless you have schizophrenia, bipolar disorder, or a really severe personality disorder with high risk, it's really hard to get anyone from a mental health perspective into adult mental health services. So it's not just you guys who I presume are getting referrals rejected from CMHT and from adult mental health services. We have exactly the same problem. And
will there be a chance for questions after
at the end of this, you can ask any questions of any of the three of us. We predicted there might be a lot of questions, so we wanted to leave time for that. And as a result of this, as we know that AMS and SANS are very swamped, long waiting lists, very high thresholds, in CAMS we're really keen that if, and from an ADHD perspective, if we diagnose at 18, we then titrate, we get them stabilised. It doesn't matter how long that takes. I've got 20-year-olds on my caseload, someone about 10, 21 that I'm still looking after because I can't find anyone else to do that. We will keep them on. So we will keep them on, we will get them as stable as possible before we discharge them, because that's the right thing to do. I'm not going to go through this. I've got 3 slides that look like this. These are all support whilst waiting. So this was something else that was asked, was you guys were saying these people are on a long waiting list. What do we do to support them while they're on those waiting lists? So these are a mixture of local and national offers. Most of these are local offers, actually. So some of these you don't need a diagnosis for, some of them you do need a diagnosis for, and I've tried to sort of say that to flag up which ones are which. And I think you guys get all these slides right, so you should have these, and all the links and stuff are there as well. So Neurodiversity Sheffield, which was formerly the Sheffield ADHD project, is really, really excellent. We refer to them routinely to do some of our ADHD follow-up, sort of more generic supports that's non-medication based once we've diagnosed young people with ADHD. But they also have an early support pathway where no diagnosis is necessary, and it's run by professionals from both Reigate and CAMS who help to support that. So I think we will have questions for all of us, not just me. So.
Just want to mention that we're aware of the treatment gap, and it's causing a lot of moral distress for clinicians, but there is active work in Sheffield now to join forces, hopefully citywide, and try and reduce this treatment gap. And there is input from our adult colleagues, and at meetings I think there is hope of a pathway for ADHD, and it's all hot off the press, work in progress, because we're aware that this is not satisfactory, this treatment gap. So, any questions? So we need to pass the microphone, don't we? So we've got a roving mic, yeah.
Couple of things, because we've had some issues in our practice itself. I mean, SANS waiting list is 8 years. They should accept transitional care, because I've had discussions from that side of things. It's staggering because, as you say, if you guys got an 8-year waiting list, I could refer a child at age 8, they won't be seen until 16, Reigate will bounce them to SANS, who will spend another 8 years on that waiting list, and they will see for 3 months and then discharge, and then apparently they should stay involved in a shared care protocol. The whole idea of a shared care protocol with ADHD meds is a specialist should be involved. They don't have to necessarily be seeing them all the time, but if I've got an adult patient with ADHD inquiry and I need a dose change needs to happen, I can refer back to them, like SANS can be referred back to them when they're kept on a caseload. So a little bit of what you said today doesn't quite make sense, and I appreciate, I suspect you know that as well from the treatment gap as well, but it's genuinely, and I'm sure you find it's infuriating, because as the GP we hold these patients, that I can refer someone at age 9, if I've got a 9-year-old, I cannot refer them to Reigate anymore.
So there's, there is active work linking with our colleagues. The waiting list, if you've already waited that long, that's added in to the adult wait. So you don't wait twice. And Rachel actually will probably be able to give more accurate information, but there's work now, isn't there?
Yeah, so the ADHD ones we're currently not transferring at 16 or 18. We are doing that. We've started doing that with some of the autism assessments, but whatever provider they go to, which is SANS autism assessments currently, they have to honour the weight they've had already. That answers some of the question, but I know it doesn't answer all of it. But you've only got the paediatricians here, I'm afraid.
Yeah, and we knew shared care was going to come up. We knew it was going to be contentious, so I'm going to try and stick to the facts. So from a shared care perspective, I'm aware that you guys don't have to sign up to a shared care protocol. There is a shared care protocol in Sheffield which states that secondary care do not stay involved if the case is a straightforward ADHD case. So the exceptions to that are if the young person has severe mental health problems, so significant substance misuse problems, at risk of homelessness or unstable kind of family life, then they can be considered for transition to SANS for shared care. It doesn't necessarily mean they will be accepted, but they can be discussed. If the young person is on a stable dose of ADHD medication and they're otherwise pretty stable average person without those things I've just listed, the shared care protocol states they are discharged from CAMS, they are not referred to SANS, SANS do not stay involved or get involved, and primary care take over the care of that young person's prescribing. That's what the shared care protocol says. It's a shared care document which outlines when shared care is appropriate and when it's not appropriate. So the shared care that's currently in place in Sheffield, which I'm aware you don't have to do, but the shared care in Sheffield does state that secondary care do not stay involved with the vast majority of cases because they are straightforward.
That's adults. So
That's a transition.
yeah. So in children, all will be linked to a secondary provider. All of them will be. So that's for adults. Yeah. And I guess once you're stable and optimised, that should be your dose. I know sometimes adjustments are required, and there is a treatment gap, and it's not comfortable. It's causing moral distress for all of us.
It's not shared. And that's the thing, isn't it? Is that shared care is supposed to be this thing whereby I can hold methotrexate prescriptions because I know I've got a rheumatologist I can call them if I've got an issue. If I'm holding an ADHD prescription and the official line is I can't get hold of a specialist or I can't refer back into service, then I'm out. But I know that's going to disadvantage my patient, so I'm going to send them back at the specialist and say, sorry, but this isn't shared care. And shared care was designed to allow GPs to hold prescriptions that would otherwise not be initiated and started by primary care. Like I would not dare have started methotrexate, but we quite happily take it when rheumatologists get on board. ADHD meds fall into that particular category itself, so unless the traffic light status changes and there's a fundamental rethink about how that is, it's shared care, but it's not shared care, and it puts us GPs in a really
But just to clarify, you're talking about 18 plus now, aren't you? Because under 18, there's a very clear shared care protocol in place, which is in place and does happen, and I'm not aware of any case where a young person under 18, where they're being discharged on ADHD medication and there is no shared care in place, because I know that from a CAMS perspective and a Reigate perspective, all under 18s on ADHD medication are under shared care.
And I think Reigate's fine with that. SANS should accept them, and if you said the SANS don't accept them, and I've spoken to SANS, and if they get the working process, they should accept them onto a transitional basis.
No, it's really clear. SANS will not take them. So from answering your question around what do you do in terms of if you have questions, so SANS's response is that there is an inquiry line which is open to GPs, which is designed specifically to answer medication questions. Should there be a question about maybe this person's coming to you in a GP appointment saying, I think I might need an increase in my dose, for example. So you have an inquiry line which you can contact, and that's your link in with the specialist. I didn't write the shared care protocol, but the shared care protocol does state that SANS do not remain involved, and it does get discharged at 18 to primary care. Rightly or wrongly, that's what it states. But yeah, there is a link in, and SANS are really keen to say, you guys use this, please use this communication line, this communication email to get the advice and support that you need from an ADHD medication perspective, because they're aware that there is a need for it, hence why they have provided it.
And in Sheffield, we are aware of the treatment gap, and there is active work now and discussions citywide to look at this and see what we can do. It's already started. And some of your GP colleague representatives are part of that work to try to, I guess, resolve the situation as much as it's possible. So we're aware there's a treatment gap, and we are really working hard to resolve it as best we can.
There's a couple of one over there. I don't know if you wanted to go over. Yeah.
Thank you. I'm sorry if I missed this, but what do we do with 16 and 17-year-olds, especially from an ADHD point of view? Because SANS says from 18. I know from for autism they are accepting.
So SANS is from 16.
From 6 for
For both conditions.
For both
yeah.
conditions. Okay. And then you did not address anything to do with the medication availability. I'm not sure if that has improved, but that has been causing a lot of problems.
So yes, I can comment on that from the paediatric perspective. So every single youngster that's on medicine that's linked to Reigate, if there's a problem with their medicine, there's a number that they can ring, and our nurses will look at what's available. And generally speaking, things are much better. So the non-stimulants are completely available. The amphetamines are completely available. There is a new stock issue with 8-hour methylphenidates. The 12-hour methylphenidates are coming back into stock. So the young people can do that. I guess we would be able to address it, but it would be a whole lecture in itself. But we can certainly arrange a time to talk about medicine swaps and that kind of thing, because it's not difficult, but I get it needs support and education. But in 15 minutes, there's just too much to cover.
Can I ask a question about sleep in neurodivergent children, and what we are supposed to help, how we can help parents, given that there is no access to melatonin other than via a specialist prescribing?
Yeah, so there is a sleep pathway. So we need to see that the young people have had support from for their sleep hygiene from FIS or from the 0 to 19 team, and then they can be referred on for melatonin preparations once that's completed.
Even without a diagnosis?
You can get melatonin preparations through the Sheffield Children's Hospital sleep team without diagnosis, yeah.
Would you suggest that we start melatonin at all in general practice or not?
I think currently the pathway is not recommending that you refer in for sleep support first. Melatonin I think does have a role, but there are also other things that can help too. And I think that's why we're keen to avoid going down melatonin as a first instance, yeah. Having said that, it is really a lifesaver for some families, so, it's going to be up to you in the end, but currently the recommendation is not to begin with.
You described ADHD diagnosis as requiring impairment of function, and you showed a self-scoring questionnaire, and I was wondering whether those that, obviously impairment of function is probably subjective, and those that, as you say, have high IQ probably mask it more. Is there evidence that reduction in life expectancy and the risk that you described, does that transfer across to those that are perhaps less impaired functionally and therefore don't get an official diagnosis?
So you have to remember that any study is looking at groups, not individuals. So we're talking about at group level, and it seems to be the impulsivity side of things that's the major link, because you're more likely to smoke, drink, so it's the lifestyle that goes with it because of the poor organisation and difficulty planning as well. But it doesn't give you information at an individual level. So it doesn't mean every single person, but at group levels, that's all studies can tell us, as a group, they are more at risk. The impairment in high IQ individuals is different. So the impairment that you're going to see, because they're able to mask and compensate, is going to be in terms of energy. So you often hear this boom and bust pattern, so that they can carry it for a bit and then they're absolutely flat. Their lifestyle balance won't be balanced, so they're often not able to self-care. They have to give everything into maybe doing a job well, and they might be able to do it better than most, but at high cost to home life, because they have to spend more time and more energy. So the impairment is there, and we have to look for different features when we're looking at higher IQ individuals. So in children, it might be that they become so exhausted that they go to bed after school and they're not able to take part in activities, or they achieve but not the potential. And it's about looking at different areas of impairment, and coping isn't living. It's not living your best life, is it? So we look at different aspects in higher IQ individuals. The citywide work's really, really exciting. It is, it's really exciting to us.
Hi, can I just start by saying thank you so much for coming to speak to us today, because I appreciate must be sort of equally frustrated in the wait list that our patients and their families experience. So just thank you for that and an excellent talk. My question is, in terms of all the kind of specialist services you're talking about within Reigate, so the SALT, the specialist dental team, can we refer into those services in a child who is not currently under Reigate? So for example, they had a diagnosis of autism under Reigate, they're now struggling with, say, brushing their teeth because of the sensory aspects of that, and we feel that they would really benefit from that service. Can we directly refer into that?
Yeah, so all those things that I mentioned can be referred into directly, and they don't need a diagnosis for that. And I just want to, because I forget to say this sometimes, is that Reigate is a building or a site, and we are neurodisability, and that's just wanted to clarify that, because I think you don't realise how many services run out. There's the gait lab and the motor team, and there's the respite team. So that's just, yeah, if you are going to refer in, please refer into the neurodisability team, because otherwise they might end up in the hydrotherapy pool, So just have a think about that, yeah.
And just secondly, out of interest, in terms of ADHD and autism referrals, just as a broad figure, what kind of percentage of children referred into the service will actually then end up with a diagnosis of ADHD or autism?
Yeah,
Roughly.
Good question. It's high. So usually for the autism assessments, you're looking about 80% end up with autism diagnosis. The ones that don't get a diagnosis usually end up with a different related diagnosis, like a learning disability, or maybe referred into ADHD or something like that. So we don't think we're getting irresponsible referrals. Sometimes there's a bit of fine tuning to do about making sure we get onto the right pathway at the right time. So that's where getting as much information as possible up front is really helpful. But no, we don't think we are getting too many, if that makes sense.
Higher. Yeah, so it's much higher because we screen really well. So it's much higher. Nearly everybody that's then accepted on will get a diagnosis, unless, of course, because as they get older, they drift in and out of threshold. They retain the core symptoms, but the impairment can sometimes be less. But pretty much in childhood, it doesn't go away, because if you think about it, demand increases and increases, and those that go to uni, it really stretches your executive function, and there's no parent wraparound, so that's sometimes where things can fall flat a bit. Sheffield is actually in the process, there's been an email circulated to ourselves, of producing a booklet with all the help services and which do and don't require a diagnosis. So that's some work in progress that's current.
Hi, hopefully my questions are quite simple. I'm currently writing our Right to Choose shared care practice policy. I'm trying to make it as comprehensive for patients as possible. And there's just a couple of things that, firstly, if a patient diagnosed on Right to Choose and commenced on treatment, I suppose for adults and children, I've read that sometimes you guys or the adult services won't accept that Right to Choose provider's assessment and diagnosis, and you sometimes need to reassess. I just wondered how often that's happening.
So in terms of autism, I think we would accept the independent providers, but where we're going to be a prescribing clinician, then obviously we do need to revisit that, and that's the same if you move from one independent provider to another. And that's because there isn't across the UK a unified pathway. Everybody does things differently. And some independent services are very thorough, they use QB check, they get questionnaires, and it's, you know, really comprehensive, and others are less so. So we wouldn't discount that, but we would meet that individual and just verify that we agree with that, you know, and they have to, they don't jump the queue, they retain their position.
Have you ever reversed a diagnosis that a right to choose provider has made on reassessment?
Yes. Quite simply, yeah. We've had one where this was this right to choose or private? This was right to choose someone that was diagnosed as a young person with autism, and we said no, this isn't autism, this is ADHD, and we actually reversed it and added the other one in. So it does happen, and I reviewed a report the other day from someone who had a private assessment actually for ADHD, and I just thought there's nothing in here that's screaming quality. There's no nice guidelines haven't been followed. There's nothing in this report that gives me assurances that this has been done well. This young person may well have ADHD, but I can't put hands on heart and say that report is actually justifying it well enough. So we'll have to end up reassessing this young person. So yeah, it does happen.
I was just going to say we also sometimes come across this with children who come from abroad as well, I you know, sometimes all you get is one line, and obviously if we are going to prescribe a controlled drug, we are not going to do that on the basis of one line in a language we don't understand, you know. Having said that, we're also not going to completely reassess them and take away a diagnosis that they've had for the last 15 years. So sometimes if the question is being asked about ADHD, that is one thing, isn't it? Because there's a prescribing duty there. If the question's being asked about autism, some of it's about we won't necessarily see this child if they've come from abroad with a diagnosis, but if there are things in there that doesn't quite fit, so if you see a child and you think, oh, that doesn't quite fit with what I've got written down here, or if education is saying we don't understand what this means for this child, and you know, I've taken children off antipsychotics and they have done much better. There is a bit of a re-evaluating perhaps where they come from different providers, but it does just a little bit depend on the situation.
I mean, with ADHD, if we're with a patient for an hour, we can see it in the clinic. If you train sets of ears and eyes. So we might meet them as a new patient and just chat about things. If they're already stable and optimised on medication and it's making a life-changing difference, we're not going to take it away, but we do, because we have a duty to prescribe and the prescribing clinician is responsible, we would just revisit that, and we can do QB testing, of course, on and off medicine for objective evidence.
Sorry, just one last question. Can the right to choose provider refer directly to you? Because I've heard that they all can, and so rather than us having to do the referral as well, if that makes sense.
Do you mean they've got an ADHD diagnosis?
Transferring them back into the NHS pathway.
So I think a referral would have to come, as far as I know, via the GP. But if we do get referrals, for medication, they would have to wait in the pathway. They don't jump the queue. So if anybody is going to go right to choose, we can't recommend a service, but would say, obviously, they need to be CQC registered if you're going independently. Look at Trustpilot, because you'll soon hear who isn't a great service, because people are very honest these days, so look at that. And also check they are a prescribing service. You know, why would you go to or through right to choose, wait all that time, and then you can't have the treatment if you require it?
Hi, can I just ask about the separate waiting list for ADHD and autism through Reigate? I had a patient this week who has been diagnosed with ADHD, was under Reigate for that, has been stabilised on medication, and they've been told almost certainly your child also has autism, but now you're on a separate waiting list, so to wait for 7 years. So they've recommended right to choose. Is that, I guess, the ADHD has been prioritised, so the medication is most important to help with their functioning, but is there any sort of wiggle room with that? Would a patient ever be, have the autism assessment or...
I guess it depends really, because an autism assessment isn't usually a quick 5 or 10 minutes, and our clinics literally run back to back to back to back. So to slide somebody in for an hour and a half is virtually impossible. They all run over.
Not necessarily on the same day, but then have a quicker...
And an autism assessment is generally 2 professionals, and whereas in clinic there would just be one of us. If there's somebody that's pretty well known and the evidence is there, that clinician may choose to diagnose them, but you would be using your own time, you would have to write the report in your own time, and you'd have to add them on to the end of your clinic, which at the moment is tricky. But one of the things that we have talked about is a Reigate fast pass. And, wouldn't everybody like that? Just like at Alton Towers. But, and we are looking at one-person assessments. Share our moral distress. It's not a nice time for us.
Of course. And would you always prioritise ADHD, because that can be addressed with medication?
So yeah, we do have a different waiting list for ADHD because we know it's treatable, and we are trying to address those issues. I think it is really hard, and we are trying to be very equitable and fair, but this is not going to be equitable and fair. And especially if we start looking at prioritisation, it's going to be really hard. Some of these children are honestly not going to be seen. And I think that is something that you may need to start having honest conversations with people about, because there's not a way that this is going to be easily resolved. And this is really hard, and I think, Caroline and I have both shed tears over this. This is not a situation that we wish to be in, and I don't think you wish to be in that either. But we also, we also really want to be as fair as possible. But it's a very tricky position to be in.
Thank you.
If you're saying that most of the diagnoses that come to you, or almost all of the ADHD diagnoses are diagnosed, then is there a way just sort of lessening it and, sorry, shoot me down here, but us prescribing with your help, because almost all of them are getting diagnosed,
So we are actively, at this moment, and some of your GP colleagues are involved in approaching the ICBs for funding for an extraordinarily innovative Sheffield project, and we're very excited, delighted that this hopefully will take place. Watch this space. We are experiencing moral distress and we don't want to, but we're not having an influx of staff, and we have 10,000 children to see, and we're a tiny team.
Are there any details on that innovative program that you can give us? Just to give us some moral, hype.
That is a very tricky question, and I knew that you were going to ask this. I guess it's looking at a citywide different way of working with interested individuals having funding, so that some of these treatment gaps can stop now. And the funding bid has gone in, and we're waiting for news, because we do not want this to happen to Sheffield, and we want to be innovative and lead the way.
Carol,
You want to do it? Go on then. Yeah. I'm being very careful on site, Howard.
That's all right. Hi, Steve Thomas. I work at the ICB and one of the clinical directors. I just wanted to actually ask you guys, because there's a lot of issues around challenges of prescribing, and you've used the word controlled drugs several times and prescriber responsibility. But there's a big move, both internationally and nationally, about sort of the myth busting relating to that, and particularly the terminology about prescribing for ADHD being like the new type 2 diabetes, you know, sort of, whereas 30 years ago we wouldn't even sort of prescribe anti-diabetic medications that go into secondary care, etc. Is there something that you can say a little bit about that? And while you think about that, I'll just build on Caroline's response there. We are definitely looking at one project, particularly with the university practice, if it can be funded, to look at a diagnostic and prescribing and titration sort of service, and to help us as general practitioners to build on those skills and look at areas where, you know, GPs with an extended role, those that sort of maybe opportunities within PCNs, etc. This is not unique to Sheffield, is it? This is a national sort of problem as well. But, you know, Caroline's right, we're looking at innovative pathways.
So there's lots of questions, so I'll be really quick. But our confidence with stimulants has increased massively, and there's evidence behind us. And actually, the worry is ADHD carries its own individual risks. So if you've got somebody that's on stimulants, we'll do more harm by stopping them and not sharing care. And most families now can do their own observations because we want BPs and pulses in range. They can go to the chemist, they can buy monitors. So we really need your help while this project gets off the ground. But long-term cardiovascular risk is negligible if we keep BP and pulse in range. Growths, there are some studies that show that there might be a centimetre loss, but there are equally studies that show there isn't. And in well-monitored clinical practice, it should not happen because we're monitoring and the weight would drop before the height. In terms of encouraging substance misuse, absolutely no. It's the other way around. We're more likely to prevent it. And, you know, I share your difficulties because I was a lone paediatrician not so long ago, you know, and we were very wary, but things have massively moved on because of the evidence. I think this
always happens when you see it. All questions have been answered, but I was just wondering if there was, I guess, it would probably involve QB testing locally and an abbreviated practitioner input in terms of prescribing, specialised prescribing. But is there any chance that there's going to be some non-CD type drugs that would make it a bit easier for us to practice?
So I've just come back from the World Congress, and I thought, oh gosh, you know, worldwide there's got to be lots and lots of exciting ADHD medicines, and the answer's no. There isn't anything on the pipeline, no. Not that we don't know about already.
Thanks very much.
Mm-hmm.
Can I just ask one quick question? It just relates to what Andy was left now. In terms of the evidence base, just knowing how that shifts in terms of time, you talked about the sort of changing landscape of more atypical presentations of more women being diagnosed. And I just wonder what the evidence base is for that. As in, when you're talking about those long studies, they're probably majority male, majority traditional presentations. What's the kind of new stuff that's coming for the atypicals, and how included are they in the research base?
So when I went to the World Congress last week, there's a very exciting project led by 3 clinicians that have written the DIVA, the diagnostic manual that we use as a structured questionnaire. And there's a QR code, and they're actually collecting lots of information worldwide to try and help us answer the question. That we heard about lots of projects, some in the UK, some outside, that some are just about to finish collections, some are mid-collection. So more and more information's coming through all the time. The evidence for the hormonal differences is clear, if that's what you're asking.
Well, I guess you showed the longitudinal study that was from taking people from 4 to 11, I think, so that must have been done some years ago.
Oh, yes. So Russ Barclay's study, yes, that was from, the 7th, yeah.
So thinking about what the risk might be to that specific group,
So there's...
like
So the pivotal study, the MTA study, that we had to look at before NICE guidance, continued naturalistic follow-up into adulthood. And, you know, they haven't showed increased cardiovascular risk. There are some studies that they, at World Congress, sort of pulled apart a bit, really, because they were linking mortality to ADHD medicines. But when you looked at the cause of mortality, it couldn't possibly be linked. It was like poisoning and things like that. So it's really about looking at the data carefully, because there's an association and there's a cause. So it's looking at the data carefully. What we do know is these medicines do increase pulse and blood pressure. That has to be monitored. And if it's raised, we have to treat that to keep the safety. There's a 2-year follow-up study that was completed that showed that hypertension, though, resolves at night, and the cardiologists feel that's very protective, and that there was no increase in ECG parameters or scans, you know, cardiac scans. It's really keeping those parameters in the normal range.